Good evening, everyone, and welcome to the webinar on the theme ALK Positive Lung Cancer Updates. It gives me great pleasure to invite our speaker, Dr. Abhishek Anand, Senior Consultant and HOD Medical Oncology, Paras Health, Patna. Over to you, sir.
Thank you, and thanks to Takeda team for this opportunity. Let me share the slides. So, very good evening to all of you. I will be speaking on the strategies in the management of ALK positive NSCLC with ALUNBRIG, that is brigatinib. This is the disclaimer. So I'll be presenting today by next 30 minutes or so about the disease overview of ALK positive NSCLC, ALUNBRIG clinical overview, ALUNBRIG safety and the dosing profile, and at the last the summary of the trial and data we have for the ALUNBRIG. Coming first to the disease overview of ALK positive NSCLC. So, if we talk about the lung cancer epidemiology and survival, it is the most commonly diagnosed cancer and the leading cause of cancer mortality worldwide. If you go by the Globocan 2022 data, the incidence of lung cancer is 2.5 million each year, and if you talk about the mortality, it is 1.8 million. So most of the patients who are being diagnosed with lung cancer are dying because of lung cancer. One of the major reason is that the patients who are being diagnosed with lung cancer are at an advanced stage. If we talk about NSCLC, the most common subtype of lung cancer is the NSCLC, that is 80 to 85% of the all lung cancer patients, and is highly heterogeneous with different driver mutation that also includes the ALK rearrangement. Stage-wise in India, if we look at the data, distant metastasis patient at the time of presentation is somewhere between 45 to 50%. However, in clinical practice, we see almost 70 to 80% of the patients coming in the distant metastatic or stage 4 or advanced stage. And if we talk about the 5-year survival of lung cancer, in the stage 4, it is dismal, it is around 10% only. So this is the lung cancer histological classification. There is a non-small cell lung cancer that represents 85% of the lung cancer patients. And then there is a small cell lung cancer that represents around 15% of all the lung cancer patients. And when we talk about the lung cancer, NSCLC has been further subdivided based on the histology. Adenocarcinoma, that is around 40%, then squamous cell carcinoma around 25%, other and not otherwise specified 20%, and large cell carcinoma type is around 15% of the patients. Adenocarcinoma histology is mostly associated with driver mutations, and more than 50% of the patients with adenocarcinoma will be having some kind of driver mutations. The most common is the EGFR, and we have got the ALK rearrangement that is seen in somewhere between 3 to 5% of all the NSCLC patients. So there are some important clinical features that is associated with ALK positive NSCLC. So most of the patients with ALK positive NSCLC are non-smoker or a light smoker. So we have seen that it is not associated with smoking, as most patients have no or light, that means less than 10 pack years of smoking history. Most ALK positive NSCLC are adenocarcinoma with few reports of squamous cell pathology as well. Around more than 50% of the ALK positive tumor show a solid growth pattern, and more than equal to 10% of the patients will be having signet ring cells histology. They are usually younger patients at the time of diagnosis as compared to the usual non-small cell lung cancer population. If we talk about the median age at diagnosis, it is 52 years for ALK positive NSCLC, and for overall population of NSCLC, it is 71 years. Most ALK positive patients have advanced disease at the time of diagnosis, and most of the patients are at stage 4, and they have a specific organ metastasis that differs from the patients those who are having no ALK rearrangement. The common metastatic sites includes the pleura, that is around 73%, brain, that comprises 15 to 35%, liver 26%, and pericardium, that represents around 20% of the metastatic site. More frequent brain metastasis is seen in patients who are having ALK positive NSCLC as compared to NSCLC with any other driver mutations. The importance of quality of life in ALK positive metastatic NSCLC is increasing as the patients live longer. If you see the data, patients with ALK positive NSCLC are typically younger as compared to the patients with usual NSCLC population. While the median age of diagnosis in NSCLC is 70 years, the median age of diagnosis for ALK positive NSCLC is around 51 years. With the survival outcomes improving in metastatic NSCLC, patients do spend more time on therapy, and with the availability of the newer generation ALK TKI, the median overall survival for stage 4 ALK positive metastatic NSCLC is as high as 6.75 years. So, as the patient spends more time on therapy, important things we need to consider is that how much is the efficacy in the brain of the drug which we are using due to the brain metastasis, which is very common in ALK positive NSCLC. Then long-term tolerability of the ALK TKI which we are using, and reduce the pill burden. So these are the three important things which we need to consider while planning for any ALK positive metastatic NSCLC patients. Also, there is importance of health related quality of life as a treatment attribute, and one of the study, that is the ALK Connect Patient Insight Network study, found that 88% of the patients living with ALK positive NSCLC rated improved health related quality of life as a very important treatment attribute. Patients currently treated with ALK TKI reported better quality of life than those who are not treated with ALK TKI, or those who are being treated with some kind of chemotherapy or chemoimmunotherapy. So with a high rate of incidence in ALK positive metastatic NSCLC, brain metastasis can significantly impact patients' life. So at the time of diagnosis, ALK positive metastatic NSCLC patient, around 35% of the patient will be having brain metastasis, and during the course of their disease, up to 75% of the patient will eventually develop some kind of brain metastasis. And this brain metastasis has got potential effect on the patient that includes behavioral and personality changes, headache, convulsions and seizures, and cognitive issues including speech problems. Patients with ALK positive metastatic NSCLC are relatively young, and the effects of brain metastasis can be debilitating, especially for those leading busy, active lives and for those raising families. ALUNBRIG has been approved, and these are the indication and usage. US approval or the FDA approval was done initially. That is, and that said that ALUNBRIG is a kinase inhibitor indicated for the treatment of adult patients with ALK positive metastatic NSCLC as detected by an FDA approved test. European and Indian approval are also there. It is indicated as monotherapy for the treatment of adult patients with ALK positive advanced NSCLC not previously treated with an ALK inhibitor. It is also indicated as a monotherapy for the treatment of adult patients with ALK positive advanced NSCLC previously treated with crizotinib. Dose and administration. So it is started as a 90 milligram once a day dosing for the first 7 days, and then the dose is increased to 180 milligram per day, that is given orally. It can be taken with or without food, and the doses form and the strength includes 180 mg and 90 mg, and these two strengths are presently available in India, and we have got also 30 mg that is globally available. So we talk about the NCCN clinical practice guidelines for ALK positive NSCLC patients, how to approach a patients who have been detected with ALK rearrangement. So if the patient has been detected with ALK rearrangement, we need to see if the patient has already been started on some kind of systemic therapy because of any kind of symptoms or not. So if the patient has been started with some kind of systemic therapy, we have to interrupt the current therapy and start with the ALK inhibitors, that includes alectinib, brigatinib, insatinib, or lorlatinib. These are the four preferred TKIs, and we can also use the ceritinib or crizotinib. If the ALK rearrangement has been discovered prior to the first line systemic therapy, the preferred TKIs include alectinib, brigatinib, insatinib, and lorlatinib, and these all are NCCN category 1 recommendation. And ceritinib and crizotinib can also be used in certain circumstances. Upon disease progression, biomarkers must be retested to determine the mutational status that will inform us the future treatment possibilities. Let's have a clinical overview of ALUNBRIG and the data we have for the first line as well as the second line treatment for ALK positive NSCLC patients. Indication and uses we have already discussed. It is indicated as monotherapy for the treatment of adult patients with anaplastic lymphoma kinase positive advanced non-small cell lung cancer, those who have not been previously treated with an ALK inhibitor, and it is also approved and indicated as monotherapy for the treatment of adult patients with ALK positive advanced NSCLC previously treated with crizotinib. So this is the study ALTA 1L. This is the randomized open label multi-center trial, phase 3 trial of ALUNBRIG, designed to demonstrate first line clinical benefit and safety. So around 275 patients were enrolled with locally advanced or metastatic ALK positive NSCLC without any prior treatment with ALK inhibitor. One regimen, one or less than one regimen of prior systemic therapy in the locally advanced or metastatic setting were allowed. Patients were randomized 1:1 to receive ALUNBRIG. That was the dosing was 180 milligram once a day with a 7-day lead in at 90 milligram once daily, and this was compared with standard of care at that time. It was crizotinib 250 milligram twice a day. Stratification factor being baseline CNS metastasis and prior chemotherapy in locally advanced or metastatic setting. The important part of this trial is that crossover from the crizotinib to ALUNBRIG was permitted after disease progression, and around 44% of the crizotinib patients crossed over to ALUNBRIG after BIRC assessed objective progression. So if we talk about the other two trials of alectinib and lorlatinib, crossover were not allowed in those trials. Here the crossover was allowed. And the primary endpoint of this trial was progression-free survival according to the RECIST criteria as evaluated by blinded independent review committee. Secondary endpoint being confirmed overall response rate, duration of response, intracranial overall response rate, intracranial duration of response as evaluated by BICR, and the overall survival. Median duration of follow-up at the time of second interim analysis data cutoff was 22 months after the last patient was enrolled, with a median follow-up of 24.9 months for ALUNBRIG and 15.2 months for the crizotinib. This is the uh, patient profile, and this is the population reflective of real world patients. Median age was 58 years for ALUNBRIG arm and 60 years for crizotinib arm, and 50% of the patients were female in ALUNBRIG, 59% in crizotinib were females. Race-wise, Asian population comprised 43% of the patients in ALUNBRIG arm and 36% in the crizotinib. ECOG performance status of 1 or 0 was 96% in both the arm. Important thing is that prior chemotherapy were given to 26% of the patients in the ALUNBRIG arm and 27% of the patients in the crizotinib arm, and baseline CNS metastasis were present in 29% of the patients in the ALUNBRIG arm and 30% in the crizotinib arm. Stage wise, 94% of the patients were stage 4 in the ALUNBRIG and 91% in the crizotinib arm. So if we see the primary endpoint, that was progression-free survival, there was more than 3 times improvement in the median PFS for uh, brigatinib as compared to the crizotinib. If you see the median PFS, that is the investigator assessment ITT population, it was 30.8 months for ALUNBRIG, and it was 9.2 months for patients who were enrolled in the crizotinib arm. So there was a 57% reduction in the risk as compared to the median progression-free survival. So ALUNBRIG demonstrated powerful systemic efficacy in the ALTA-1L study. Coming to the intracranial efficacy, if you see the data, ALUNBRIG demonstrated intracranial median PFS of almost 4 years in patients with and without brain metastasis as compared to the crizotinib. So this is about the intracranial median PFS for all the patient, whether the patient is having baseline brain metastasis or not. The median intracranial PFS for ALUNBRIG was 44.1 month, and for the crizotinib arm it was 21.2 months. So again, there was a risk reduction of 56% if we talk about the intracranial median PFS. So there was a long-lasting intracranial response as compared to the crizotinib, and the median intracranial PFS in patients with any kind of brain metastasis at the baseline was 24 months in the ALUNBRIG arm and 5.5 months in the crizotinib arm. So this was almost 5 times better for the ALUNBRIG as compared to the crizotinib. Also, ALUNBRIG provided a 71% reduction in the risk of intracranial disease progression or death. The complete response rate was 45% in the ALUNBRIG, and it was only 2% in the crizotinib arm. The median duration of confirmed intracranial response was 27.1 months for ALUNBRIG, and it was 9.2 months with the crizotinib. So again, it was almost 3 times better for the ALUNBRIG. Patients with measurable brain metastasis at the time of at the baseline, ALUNBRIG again demonstrated a longer overall survival as compared to crizotinib, and 7 out of 10 patients with brain metastasis were still alive at the end of 4 years. Patient reported quality of life with ALUNBRIG. ALUNBRIG delayed time to worsening in global health status and quality of life. And here you can see the median time to worsening in global health status and quality of life was 26.7 months for ALUNBRIG, and it was 8.3 months for the crizotinib. So it depends on the physical scales, emotional, cognitive, and social functioning scales, as well as the improvement of the disease symptoms. Another important slide is about the clinical activity to all the 14 ALK mutation. So this is the preclinical data that suggests that ALUNBRIG is active against all the ALK variant, the 14 ALK variant, which is known to us presently, and it is almost comparable to the lorlatinib if we talk about the IC50. And here you can see the common ALK variant G1202R and L1196M. The ALUNBRIG has got significant activity in the preclinical data. A bit of comparison of the other two important ALK inhibitors, that is alectinib and the lorlatinib. So there are some kind of study changes which we can see here, that if we talk about the alta 1L, prior chemotherapy were allowed and one prior regimen were allowed in the alta 1L study, and in the LX as well as the crown trial there were not allowed. So it was directly started with ALK inhibitor, either it can be alectinib or lorlatinib as in comparison with the crizotinib. Crossover was allowed in Alta 1L, and we have seen that almost 44% of the patients who were started on crizotinib were crossed over to ALUNBRIG arm at the time of disease progression. However, this crossover was not allowed in the LX trial for alectinib and the Crown trial for the lorlatinib. So the Alta 1L, LX, and the Crown studies aim to determine the efficacy and safety of newer ALK TKI versus crizotinib. That is the first generation ALK TKI. That was the standard of care when these trials were designed. Another retrospective chart review was done to see the effect of second line and beyond ALK TKI after the use of ALUNBRIG in the first line setting. So if you see the second line lorlatinib and alectinib, they did much better after the first line brigatinib. Here you can see the real world PFS2 was 74.7 months for patients who were started on lorlatinib at the time of disease progression on brigatinib. Coming to the second line ALUNBRIG, this is the ALTA 2 study. It is an open label, single arm, multi center, international phase 2 study. Here the patients with age more than equal to 18 years, stage 3B or 4 ALK positive NSCLC, those who have progressed on alectinib or ceritinib as most recent ALK TKI and have received less than equal to 3 systemic anti-cancer therapies were enrolled and were given ALUNBRIG at the dose of 180 milligram per day. And at the time of disease progression, the options were either to increase the dose of ALUNBRIG to 240 milligram per day, continue brigatinib at the same dose until clinical benefit, or discontinue the ALUNBRIG. The primary endpoint was confirmed overall response rate, and the key secondary endpoint being overall response rate, that was investigator assessed, duration of response, PFS, disease control rate, TTR, OS, safety, intracranial data, and health related quality of life. So this is the baseline characteristics of ALTA 2. Median age was 56 and 52% of the patients were female. Asian versus non-Asian, it was 48 versus 52%, slightly more of non-Asian population in this study. And disease stage at the time of entry was most of the patients were of stage 4 disease, of course. Prior alectinib were given in 84% of the patients, and prior ceritinib were given in 17% of the patients. So if you see the overall response rate by IRC assessment, the confirmed overall response rate was 26.2% in the intention to treat population, and post alectinib it was 29.1%. Median duration of response was 6.3 months for the overall population, and for post alectinib it was 5.9 months. Disease control rate, it was 54.4% and 54.7% in the ITT and post alectinib. Intracranial overall response rate, it was 15%, and intracranial PFS was 5.2 months. So this is decent enough data if we talk about the second line ALK inhibitors after the progression on the first generation. So the safety profile of Alunbrig in the ALTA 2 was consistent with the previous studies, and the most common treatment related adverse events include the CPK increase, diarrhea, nausea, lipase increase, AST increase, ALT increase, amylase increase, and hypertension. And Alunbrig, though, thus has demonstrated clinically meaningful activity after next generation ALK in a number of clinical trials and the real world studies as well. Coming to the safety and dosing of Alunbrig, so this is the safety profile of ALTA 1L study, and very interesting is that 3% of the patients in the Alunbrig arm had early onset pulmonary events, that is within 14 days of treatment initiation, and all the 4 patients with early onset pulmonary events discontinued brigatinib after the event as per the protocol. So ILD pneumonitis of any grade occurring in any time was seen in 6% of the patients in the Alunbrig and 2% in the crizotinib. Grade 3 or more ILD pneumonitis at any time, it was 3% and less than 1% in the Alunbrig and the crizotinib. And ILD pneumonitis of any grade with early onset was seen in 3% of the patient in Alunbrig and none in the crizotinib arm. The recommended doses for Alunbrig, so we have to start with 90 milligram orally once daily for the first 7 days and then increase the dose to 180 milligram orally once daily. Administer Alunbrig until the disease progression or unacceptable toxicity. If Alunbrig is interrupted for 14 days or longer for reasons other than adverse reactions, resume the treatment at 90 milligram once daily for 7 days before increasing to the previously tolerated dose. Alembic tablet should be swallowed whole and it should not be crushed or chewed. Inform patient to avoid grapefruit or grapefruit juice while taking Alembic as it can cause drug-drug interaction. If a dose of Alembic is missed or vomiting occurs after taking a dose, do not administer an additional dose. The next dose should be taken at the scheduled time. To summarize, Alunbrig has got a powerful systemic efficacy, and the BIRC assessed PFS shows that the median PFS is for 24 months with Alunbrig and 11 months with the crizotinib. In this ALTA 1L study, the investigator assessed PFS at the time of final analysis. The median PFS was 30.8 months with the Alunbrig and 9.2 months with the crizotinib. It has got a durable intracranial efficacy, and the BICR assessed intracranial PFS at the final analysis. It suggests the median PFS was 44.1 months with the Alunbrig and 21.2 months with the crizotinib. Brain metastasis population, it has got a superior intracranial efficacy, and Alunbrig reduced the risk of progression or death by 75% as compared to crizotinib. The median PFS was 24 months with Alunbrig versus 5.6 months with the crizotinib. This is the intracranial median PFS. In the ALTA 1L, the most common serious adverse reaction other than disease progression were pneumonia, ILD, pneumonitis, pyrexia, dyspnea, pulmonary embolism, and asthenia. So the dosing that fits into patients' lives, we have to give only one tablet once daily with or without food. So this is Alunbrig Alta 1L data we have with us, and this is now the standard of care for the upfront ALK positive metastatic NSCLC patients. With this, I would like to conclude. Thank you.
Thank you so much, sir. I would now like to invite our moderator, Dr. M.V. Chandrakanth, Academic Head and Medical Oncologist, Narayana Super Specialty Hospital, Kolkata. Sir, requesting you to please invite your panelists.
Right. So let me invite Dr. Moses Dr. Saroj Das Majumdar, and Dr. Paulomi, Dr. Naresh Jadhav as panelists.
Good afternoon, all.
So Dr. Paulmi will be logging in soon, sir.
Right. I'm just trying to share the presentation. One second. Sophia, can you share it from your end?
Sure, sir.
Yeah. I'm not able to get it. You have sent in WhatsApp. Uh, yeah, I got it. I'll share. One second. No, nothing. This is a different one.
Do you want me to share it with you again?
You share. In the meanwhile, just mail me the presentation.
Okay, sir.
You share it here. I'll be moderating, and then I will.
Okay, sir.
Right. You mail me in meanwhile. I'll just share after a couple of slides. Okay.
Okay, sir.
Thank you. Okay. So right. So today we will be navigating how best to handle. Right. How best to handle an ALK positive non-small cell lung cancer? What are the treatment options we have? These are the disclaimers. Okay, next. So let's go through the first line treatment sequencing based on the existing clinical data. Next. So this is the first case we have. It's a 43-year-old lady, so never smoker, well preserved. So what she has is a conglomerate lymph node mass in the right side of the neck. She has headache, visual disturbances, lack of appetite, weight loss, and she has been treated for depression at 38 years of age. Right. So let me start. History, if you have a history of a psychiatric illness, so what implication it has is what we should. So, Dr. Naresh, you want to take up this? So, if there is a history of depression, psychiatric illness, visual disturbances, does it have any implication for choosing any treatment?
Uh, yes, I mean, somebody who has a history of psychiatric issues, number one, we need to assure that the patient has got good social support, whatever treatment that we are planning to offer. Second is any therapy that, I mean, we should also be able to, say, distinguish the symptoms possibly due to intracranial metastasis from the psychiatric manifestations of the patient. So that can be challenging at times because over a period of time, depression and all those things can be a component in many cancer patients, especially those who are a metastatic or a stage 4 disease. And third, last but not least, we should be careful with drugs that have got CNS toxicities, especially when we are using certain TKIs. Some of them are known to have certain CNS or neurocognitive dysfunctions. So that you will have to be careful whether it is drug related, disease related, or the psychiatric illness related.
Excellent point, Dr. Naresh. You summarize at every level. So yes, history when you have a psychiatric illness, we don't know in future whether it will be a TK induced or whether it is due to the psychiatric illness per se. It's important again, visual disturbances. As we know, a drug like crizotinib can cause visual hallucinations. It can. So these are important to understand. Okay, next. Well, so we go back to that. Yeah. So it's T4NV M1B with multiple brain metastasis. So this is the presence of brain mets at baseline. So this is an important thing. So let me ask Dr. Moses. Dr. Moses, good evening. So do you feel if you have brain metastasis, does this influence the choice of treatment?
Hi, good evening. Yes, definitely the presence of brain metastasis definitely influences the choice of first-line treatments. I would like to choose uh, an ALK TKI which has good intracranial response, preferably a second generation or third generation ALK TKI over a first generation. Especially in this patient, since he is also symptomatic.
Right. So you would not be comfortable giving crizotinib for a patient or even a ceritinib for that matter, which have a incomplete CNS penetration. Great, sir. Okay. Thank you, sir. So now this is the PET-CT report. Again, you are seeing that there are bilateral lung nodules, cervical lymph nodes, and so on. And the final diagnosis is adenocarcinoma, ALK positive, and you can see the variant 1. So now let me request Dr. Saroj. Sir, good evening.
Yeah, good evening. Thank you. Please.
Thank you, sir. Yes, sir. So, sir, in our practice, we still do a ALK IHC because it is available in one day.
Yes.
But ALK fish or a ALK NGS, it will take 1 week time. So, how is your practice, sir? Do you do NGS or you are still doing
Nowadays, yeah, we are doing at least 12 gene panel nowadays for all patients. We are doing that. So, and quickly within 1 week, we are getting the report. So, this is our practice now.
Right, sir. Right, sir. Thank you, sir. So, Dr. Naresh, if you just read through the ALK positive report, it's a variant 1 gene fusion. Any experiences, Dr. Naresh, of variant 3 versus variants 1? How was the prognosis in any choice of TKIs you make?
So, most of the reports that we generally routinely do, most of them do not actually specifically mention the variant in the particular ALK fusion. And also, the incidence of the mutation being say around at best around 5%. Individual variation wise number of patients experience is limited, but if we look at the literature, obviously the different variants tend to have different sensitivities towards ALK TKIs. Especially the variant 3 is supposedly to have the most resistance to conventional or first generation TKIs. And if you see the evidence from the subgroup analysis of the Crown study, the variant 3 seem to be doing pretty well there. So that is, there are some subgroup analysis saying that the second and the third generation TKIs, including brigatinib, they tend to, have a better sensitivity towards the variant 3. there are obviously you don't get similar degree of responses.
Again, very important message what Dr. Naresh suggested us. Variant 1 versus variant 3. It matters. Why it matters? Because variant 1 is okay, where crizotinib probably is working both in 1 and 3. But when it comes to variant 3, there is a differential sensitivity to ALK TKI. Okay, they're a second generation like a brigatinib or a lorla, they work equally on both variant 1 and 3. So that's very important. If you have a variant 3 and you're offering crizotinib, the outcomes are not great. We will show in the subsequent slides. Go to the next slide. Yeah, this is the PET scan showing multiple brain metastasis and cervical lymph nodes, making it a stage 4 disease. Next. Right. So this is the overall response. So just unshare it, no? Unshare the slides. I'll share from my end, Sophia. Right. Thank you. Yeah, I think it's visible now from my end.
Yes, sir.
Okay. Thank you. Thank you, Sophia. Sorry for the confusion. Right. So this we addressed. Yeah. So this is P53. So if P53 is there, what crizotinib does and what alectinib does, if this is a concomitant, then that's an important reason why we must do a complete genomic profiling. If you're doing hotspot or if you're doing IHC, you won't come to know the concomitant mutations that are there. And you can clearly see the variant 1 versus variant 3 and the P53 presence. Crizotinib is doing inferior in the variant 3 and in the P53 mutant population. So this is one that you need to remember. This is another slide, again showing if it is variant 1 or variant 3, in both the subsets, brigatinib is doing equally well, like it's not getting compromised. Whereas if I'm using crizotinib to variant 3, you can see the PFS is 7.4 months. And similarly, if it is brigatinib, it's 16 months. So variant 3 is worse than variant 1, but brigatinib is effective in both the subsets almost in an equal way. So that's what you can see. So both ALK fusion V3 and 53 are prognostic biomarker for poorer PFS, and brigatinib is sort of active in both the subsets. So let's go for intracranial efficacy. So this is the intracranial PFS at 4 years in patients with and without brain mets. Brain mets is extremely important. You know, we saw a presentation from Dr. Abhishek where brigatinib had significant intracranial activity, and he was taking us through the data of intracranial PFS. And you can see the ITT population here with and without brain mets. So this is 44.1 months in patients without brain mets, and it is 21.2 months with crizotinib. So this is ITT without brain mets, 56% risk reduction. And then this is longer lasting intracranial responses. Again, 2 year versus not even 6 months with only 2% CRs as far as crizotinib is concerned, and 71% reduction in the risk of intracranial progression or death. The hazard ratio is 0.29. This is important. Intracranial efficacy, 45% CR versus 2% CR. It's a lot of difference, right? So these are the positive points. You know, the primary endpoint is met. The crossover was permitted. The CNS efficacy is fantastic, and patients who had taken some chemo were enrolled. So let me request Dr. Moses. So these are some positive points of brigatinib, you know, of the trial that we had. So your comments on each one of them.
Yeah, I'm impressed by the first three, I'm not really sure how much of an impact, whether the patient has taken previous chemo, how much of an impact that has on outcomes. So I would not give importance to that, but the remaining three definitely having longer PFS, and the PFS still being met even with a crossover, and
Right.
good CNS efficacy as good as that of lorlatinib is really impressive.
Right, sir. So if you just remember Lola, I mean, there was no crossover permitted.
Yeah, so that definitely is
That's very
supposed over here.
important.
Yeah.
Yeah, almost half of them, they crossed over in this
Yes.
particular trial. And
Yes.
very importantly, sir, even the fourth point, if you see, if a patient is symptomatic, if you have sent a tissue for NGS, in the
Yeah.
meantime, we can give one cycle of pemetrexed carboplatin until the reports are available. Until then, you can actually uh, uh, there's evidence of this, of giving
Yeah,
one
I
chemo before.
entirely take that. I mean, it's just that it is their part of a randomized trial, but that is
Right.
something
So this is more,
routinely do anyway.
yes, sir. This is reflecting the practical scenario in a more
Yeah.
often way.
Yeah.
Uh, yeah, that was the point I was making. So because none of the other TKI trials, if you see, they are not using some chemo, to be given before.
Definitely. Yeah.
Right. Right. So thank you, sir. Thanks for your inputs. And this is the ALTA first line trial of brigatinib, and you can clearly see by the independent committee, the median PFS is nearly 2 years, and it's almost similar to alectinib and brigatinib. And then similarly, the hazard ratio is 0.48 in the comparator is crizotinib. And if you look into the investigator assist, again, it's very impressive. It's crossing 30 months mark. And the overall survival was immature, but remember, there was significant crossover. Almost half of them crossed over. And the intracranial response rates are very impressive, 78% response rates. So these are important points, as Dr. Moses highlighted. Right. So this is the PFS by baseline brain mets. So in the Crown trial, again, impressive uh, PFS based on brain mets present or presence of intracranial brain mets, yes or no. Both subsets are benefiting. Similarly, the brigatinib trial, presence or absence, even here it's getting benefited. Same with Alex. So, Dr. Naresh. So, Dr. Naresh, the brigatinib, as you can see, there's an excellent CNS activity, good intracranial response, almost half of them getting CR, or more than that having CR. And then the hazard ratio, impressive if you have brain mets. So, what is your opinion? Like, should we be giving only with brain mets, or we should give in both with and without brain mets?
Yeah, I mean, brain mets, if they are present, definitely brigatinib would be a strong contender because of very high intracranial activity and intracranial responses. I mean, if there is one organ where you actually a response rate actually matters, it's brain because the morbidity and the mortality associated with uncontrolled brain mets is very significant. So in patient with brain mets, definitely I would have a drug like a brigatinib, which has significant intracranial activities. And even if we see patients without brain metastasis, if we look at the previous graphs also that we have presented and Dr. Abhishek also presented that in the intention to treat population also, brigatinib has done better compared to first generation ALK inhibitors. So irrespective of the presence of brain mets, we would consider a second or a third generation ALK TKI like brigatinib, more so in patients with brain metastasis.
Right. Using a TKI, whether in the first line or in the later line setting. So this is important. So should we use crizotinib first and then reserve this TKI for the later line, or use it? You use the best TKI in the front line setting. So let me request Saroj sir, you can take up.
Yes.
So
Mm.
yes, sir. So what do you
Yes,
think?
what we do in the clinic, we see the availability and going through this Alta 1 also. First line is always the quality of life, the drug loads, everything is less. And nearly 6 years you are getting with this therapy. And also Crown trial also suggests you can go for lorlatinib also. That is what we are seeing in the clinics also. So I think crizotinib you have to choose very carefully. So uh, my choice is for second line or third line ALK inhibitors, which is brigatinib or lorlatinib, irrespective of metastasis is there or not. This is my take.
Right, sir. So why keep the best TKI back? Give it,
Yes.
in the right, in the earlier line setting for the best efficacy. Agreed, sir. So this is the treatment sequencing. This is one of the retrospective cohort study using the IQVIA's US-based longitudinal patient-centric pharmacy claims database, a long name. And again, they have used different endpoints. Time to treatment discontinuation, and then a new ALK TKI therapy. So these are some endpoints that they used, and more than 90% adherence and dose compliance score. So these were all used. And this is the adherence, 92.7% adherence, and the dose compliance score is 1, and time to discontinuation is 10.3 months. And these are the baseline characteristics of the patients that you had. And then these are the different TKIs. Lorlatinib was the most common next ALK TKI, followed by uh, brigatinib retreatment, alectinib, ferritinib, and crizotinib. So these are uh, the most next ALK TKI that was used. And these are the durable clinical benefits that existed in all patients. Treatment with subsequent ALK TKIs can still bring benefit to patients discontinuing lorlatinib. Rashmi? Dr. Paulami has joined. Okay. Okay. Yeah, Dr. Paulami, if you have joined, you can give some inputs. So if there is a lorlatinib progression, it's difficult because I have exhausted all the treatment options. If I use brigatinib and subsequently at progression, if I have lorlatinib, another option, a TK of a TKI. So what is your thought? If I exhaust with third generation TKI in the front line, I have only chemo left. So yeah, Dr. Paulami, your thoughts on the sequencing of ALK TKIs?
Yes, sir. If patients have de novo brain metastasis, then obviously third generation anti-ALK agent is our first choice. If patient already received lorlatinib or brigatinib in first line, then we have options of chemo plus immunotherapy. We can use
Right.
ABCP regime also. If patient already exhaust means first in a first line, if we used third generation anti-ALK, we can use APCP.
Agreed. So, right, Dr. Palam. So, Dr. Naresh, post Lurla is a challenge. So, you don't have a target that is because even the G1202R is taken care by lorlatinib. So, basically, you will have something that is out of ALK, if at all, if there is a progression. But if I use brigatinib, I'm actually inhibiting almost everything, and this G1202R is kept open. And I have another ALK TKI too, something like geotag with, I think if you remember, of afatinib and then osimertinib. So there was a geotag data that they showed a longest PFS. So what do you think about this sort of a sequencing? Because post Lola, I don't have any option of TKI.
Again, optimal sequencing, Briga followed by Lorla or Lorla alone. I mean, that is something, I think with time, things will be better cleared, especially when more real world data comes into picture. As of now, I mean, if you're using brigatinib in first line, we have the option of lorlatinib as a second line in terms of progression. So that is one advantage that we have. You can, you're using a good TKI in first line, and you're also keeping a good TKI in the second line also. Theoretically, that should be able to give you a longer PFS and overall survival benefit. So that is there. Whereas if you're using lorlatinib upfront, definitely post progression with lorla giving brigatinib, the data is not very, it's a very sketchy kind of data. And post lorla, you are left only with chemotherapy. So this sequence probably would give you the best outcome in terms of PFS and overall survival benefit. But we need to look at more real world data, I think, because it's the real world data that is going to give us the ideal sequencing here.
Perfect, perfect. I think that's very important point of ideal sequencing. Okay. So I think it is
But
reasonable.
Dr. Chandrakanth, don't
Yes, sir.
we do a repeat biopsy this time and see
Yeah, extremely
other
important. Very,
maybe
very
MET
important.
amplification and other things?
Correct. Exactly,
So,
sir.
okay.
Exactly, sir. So that's the point what we are saying, sir. If we have used lorlatinib in the front line, if I do a rebiopsy, it is very unlikely that I will have a ALK mutation again. The resistance mechanism is something like a mesenchymal transition,
Yes.
or as you said, a MET amplification, or some other transformation that you would see. So that is what we are making. So, but if you have used brigatinib, you have 1202R,
Yes. Yes.
which can be targeted by lorlatinib in the subsequent line. Yeah, Dr. Naresh, you were saying something?
No, that was my mistake. Sorry.
Right. Okay. Right. So that's what Dr. Naresh was also mentioning about what is called wise sequencing. Right. So, and this is the NCCN guideline. You can see brigatinib there right on top in the subsequent therapy also with brain mets symptomatic, and even in systemic disease with multiple lesions, you have brigatinib sitting there. So that shows how effective it is in the subsequent lines and also having a good CNS activity. Right. So this we completed subsequent therapy. This is the ESMO guidelines, how to treat subsequently. As Dr. Saroj was mentioning, rebiopsy is important, to understand the type of mutation you have. And depending on that, you can go ahead and use brigatinib, and the MCBS is 4 for this. Right, this is important. Safety and quality of life. So let's come to this. This is a 42-year-old lady, respiratory symptoms and diagnosis, cough and dyspnea. And this is having a pleural effusion, liver mets, multiple brain mets, ALK positive by IHC, no material for NGs, and you can see the multiple brain mets here. First line alectinib, partial response, anemia, myalgia. And this is November, 1 month on alectinib 600 BD. And then rapid growth of lung mass and ALK IHC is positive, variant 1, no ALK mutation. And second line lorlatinib done, 100 OD. And then patient developed paranoia, hallucination, weight gain, pedal edema. Right. Dr. Moses, what are the challenges of lorlatinib, side effects you face in clinical practice?
Yeah, so definitely the two of the common side effects that significant problems that we face are, one is this psychiatric issues that we face, and another one is hypercholesterolemia that we face. So these hypercholesterolemia we are able to manage now by preempting that by starting statins along with the initiation of lorlatinib. And this is also usually well manageable by giving a break and reducing doses.
Right, I agree. So, if you look into, you very correctly mentioned, sir, dyslipidemia is a common problem with lorlatinib. It causes preferentially a high triglyceride elevation
Yeah.
and also an LDL elevation. So, I mean, a good number, like nearly 20% of them, of among them who have developed dyslipidemia happens in 80% patients. And
Yeah.
among them, like 10 to 20% can have a grade 3 to 4 dyslipidemia, especially hypertriglyceridemia, and they can land up with pancreatitis. And on a long run, these guys are supposed to live long, and they are at risk for a cardiovascular disease. It's not a disease where we are losing these patients in a couple of years. They're going to live long, longer, like 5 years, 10 years or beyond. And their risk of consistent high lipid levels will make them susceptible for a atherosclerotic cardiovascular disease. And now, to combine a statin, so statins are not effective on triglycerides. So
Definitely.
statins lower the triglycerides. Let's say a dose of atorvastatin 10 to 20 milligrams, it reduces triglyceride by 10 to 15%. But if you actually want to reduce triglycerides, you need to use a higher dose of atorvastatin. The problem with atorvastatin is Lorla and atorva both
Yes.
get metabolized through the same enzyme. And
Usually
now
prefer to use rosuvastatin.
rosuvastatin. So in chance you use atorvastatin, the levels of atorva can go up and can cause something like a rhabdomyolysis like syndrome. So we need to be very careful while we increase the dose of atorvastatin or even rosuvastatin at a higher dose, let's say 20-40 milligram if you want to go, because the lipids are not getting controlled. Myopathy and rhabdomyolysis is a possibility. So it is it's difficult to handle. And for triglycerides, you need to give something like fenofibrate, and that has its own side effects. So it's a difficult game, and these are at a longer risk of if a patient has to be for 10 years, they will definitely be predisposed to an atherosclerotic cardiovascular disease. So dyslipidemia is a challenge. And then coming on to hallucinations, and this patient required discontinuation because of CNS toxicities, especially post-rate. Let's say we gave an SBRT and then immediately lorlatinib, it's challenging. So psychiatric issues, weight gain, pedal edema, dyslipidemia, these are the concerning things with lorlatinib. Right, sir. So this is the liquid biopsy at 1 month on Lorla, and you can see the rapid response, partial response, and then right. So giving lorlatinib now, subsequent in, let's say, intolerance to lorlatinib. Okay, Dr. Paulimi?
Yes, sir.
Yeah,
Sir,
doctor. So
actually,
this is a patient, let's say, post crizotinib, alectinib, and then lorlatinib had intolerance. In this patient, what do you think? You can give crigatinib for this patient?
yes, we know that weight gain and hypercholesterolemia and hypertriglyceridemia, these are the common side effects for lorlatinib. So, for elderly patient, if patients have any pre-existing means hyperlipidemia, so then we can avoid lorlatinib and we can use bringatinib for those sort of patients.
Right, right. So that's very important. Where intolerance, a significant number of patients do have intolerance to TKI or latter third generation, where you can safely use uh, brigatinib in this patient. And pill burden, the dose of alectinib is confusing. Like the global Alex has something, the Japanese Alex has something. So different Alex trials have different. So and the pill burden is high. So let me request Dr. Saroj. Sir, if you look
Yeah.
into alectinib, so 300 BD, it's in Japanese Alex. And in the global Alex, it is 600 BD. The number of pills required is high. Whereas if you
Yes.
take brigatinib, there's just one pill a day. So what is your take
Yes.
on the pill burden, sir? It's not
Yes.
for 1 or 2 years. It's for they have to take it for years together.
So definitely this is a preferable one, brigatinib. One more point, the lorlatinib that has cognitive functions effects were there. So
Right,
in
right,
brigatinib it is not there. I read somewhere. So this is also when psychiatric problem is there, you can choose brigatinib also. And patient is on psychiatric drugs with so many drug interactions you expect. So this is also one choice, brigatinib you can choose. So
right,
definitely it
sir.
is easy to compliance is better and once a day. Only issue is lung toxicity. You have to be careful. What I understand from this.
I think very important, sir. I agree. I think you made very important drug interaction is one, and the other one is the subtle cognitive disorders it causes, like forgetfulness, mood disturbances. That really is concerning, which we usually ignore in our practice. And this is the brigatinib early onset pulmonary events. Right. So this is something that Dr. Saroj was also mentioning, the lung toxicity. But Naresh, any comments on this? The first 2 weeks becomes important as far as brigatinib is concerned. How concerning this is for you?
Yeah.
How best to handle this toxicity?
Yeah. So obviously we know that with TKIs, early pulmonary events and interstitial lung disease, pneumonitis can be challenging. But now with larger use of other drugs like antibody drug conjugates, which also have an overlapping toxicity profile in terms of interstitial lung disease, I think we're getting slightly better at probably preempting and anticipating these toxicities uh, in terms of monitoring of PFTs and CT chest. Uh, only challenge is there that you should be able to differentiate between an early onset pulmonary syndrome or early onset ILD with progression of the disease or worsening of the malignancy. So that becomes an issue there. You don't know whether it's actually an ILD or it's probably lymphangitic carcinomatosis kind of picture because they look similar on a CT. And even your PFTs will look more or less similar. So that is one aspect I think which we should be careful because you don't want your patient to, stop a therapy that probably might be working in that patient. Probably shift on to a drug which is less likely to cause an interstitial lung disease.
Right. So it's early onset, as Dr. Naresh was mentioning. Disease progression or lymphangitis carcinomatosis versus the lung toxicity that we are concerned about. And you can clearly see here that not all adverse events are because of the drug itself. And this is how we handle the adverse event, that is the ILD because of brigatinib, the grade 1, grade 2, and this is how we handle, and it promptly responds to this dose reduction. And that's about it. I think the positive points of brigatinib, if we have to just summarize the way we did, number one is toxicity profile. Lipid cognition, not that concerning. This is one very important. Number two, sequencing. I have another TKI to sequence after one TKI. This is one more important thing. And number three is post chemo. Even in the first line, I'm able to use, there is some data on it. And the CNS penetration is fantastic. Like we can use it post quizartinib, post serotinib. This has wonderful CNS responses, very durable responses. And the toxicity profile is very good. The drug interactions are lesser. The pill burden is lesser. So that's important. So, and sequencing is one of the most important way of treating an ALK positive lung cancer. So I think these are the points I think we can remember. And uh, brigatinib is, yes, little bit late to arrive, but yes, a really effective ALK positive TKI that we have in practice. So I would thank all the panelists, Dr. Naresh, Dr. Moses, Dr. Paulumi, and Saroj sir for his very active participation. If any of the panelists have any thoughts, you can share. Otherwise, we can conclude the session. Thanks again for this opportunity.
Thank
Thank you,
you.
sir.